First of all, standardization and objectivity. It's very important to have in the standardized and objective tool to assess mucosal lesions and mucosa and disease activity. Subjective interpretation of endoscopic mucosal lesions will lead to eventually heterogeneity in reporting and heterogeneity in decision making and treatment of IBD patients. Endoscopic scores provide a consistent framework for evaluating disease severity and activity, reducing subjectivity, and provide an objective measurement and interpretation of mucosal lesions. Treatment guidance. Endoscopic scores can quantify the disease extent and severity and convert them into numbers and scores. And this, of course, will allow us to take informed decisions about treatment, whether escalation, de-escalation, add-on treatment, and add-on drugs, or switching between different classes, aiming for mucosal healing, which is the main therapeutic target, as we all know. Prognosis and stratification. Endoscopic scores can predict future flare of the disease, and they can predict the complication of the disease, allowing us to take preventive and proactive management strategies in those patients. Clinical trial assessment, of course, we all know that in standardized endoscopic scores are essential for evaluating the efficacy of the new IBD drugs, ensuring consistent and reliable assessment of it for treatment responses. And finally, we all know that endoscopic mucosal healing, which is assessed by endoscopic scores, has been linked to several outcomes, like reduced complication rates, reduced hospitalization rates, reduced corticosteroid use, reduced colorectal cancer, and eventually, at last, improving patient quality of life. I think if you can correct me that there is more than 15 endoscopic scoring system for IBD patients, but I'm going to highlight on the most and widely used endoscopic scores in ulcerative colitis and Crohn's disease. For ulcerative colitis, Mayo endoscopic score and ulcerative colitis endoscopic index of severity are the most widely used scores. Mayo score, of course, we all know that is very simple and easy to be applied, and it's very familiar with the endoscopists, but it's not very detailed, and it high ceiling effects and high inter-observer variability. On the contrast, in ulcerative colitis, endoscopic index of severity is validated and much detailed and reproducible and more sensitive to change, but it's more complex and less commonly used in routine and daily clinical practice. For Crohn's disease, also there are the most commonly used and widely used scores are simplified endoscopic score in Crohn's disease and Crohn's disease endoscopic index of severity. Simplified score is easier and quicker and reproducible, but less sensitive than Crohn's disease in the endoscopic index of severity, and there is no distinction between the superficial and deep ulcers in simplified score. While the endoscopic index of severity for Crohn's disease is very sensitive and validated, and it's gold standard in clinical trials, but it's complex and time-consuming. There is another score used in Crohn's disease, but in the post-operative settings, which is Rutger's scores, and it's widely used in clinical practice post-operative, and it's very, very useful in predicting and preventing recurrence after surgery in Crohn's disease. What are the supporting evidence to use these scores? We can see here most of the guidelines, almost all the guidelines and consensuses recommend usage of these scores, mainly what I have mentioned before, in routine clinical practice and in clinical trials. Even RAND appropriateness panel in 2021, which is referring a recommendation in IBD, included endoscopic scores in quality endoscopy reporting. Which means that if your report, colonoscopy report, does not include the endoscopy score, you are missing a quality measure in your report. Despite the relevance, clinical relevance, and evidence which supports using endoscopic scores in daily clinical practice, we have still challenge in applying them routinely, and we can see many reports, I think, without colonoscopy, without using endoscopic scores in IBD patients. What are the main challenges many challenges in this situation? In adherence, in accuracy, and variability, and intra-observer variability. We have non-negligible proportion of endoscopists don't include endoscopic scores in reports. Either they don't know about them, or they do know but they don't have time, or they don't know do not aware about the importance of these scores. And in addition, some endoscopists they do include these scores in their reports, but inaccurately describe these scores. So, and in order to overcome these challenges, two challenges, surveillance of adherence is very important, as we are doing in endoscopy units regarding adenoma detection rate. Providing endoscopic calculators, score calculators, and prepared or predetermined templates in the endoscopy program, as we using in routinely practice in our endoscopy units. And the key solution for these two challenges is education and the dedicated training programs, either online programs, physical or virtual programs. It's very important to apply these training programs to all endoscopists. Regarding the third challenge with the inter and intra-observer variability, again, the key solution here is practice and training. Training is the key solution for this challenge. What are the future directions of endoscopic scoring systems? Incorporating virtual chromo endoscopy is now gaining wide acceptance and wide attention because it had many advantages, like reducing the gap between endoscopy and histology, and also better stratification between the mild disease and remission of the disease. This is very important, very important. And indeed, also already a scoring system called Picasso score used virtual endoscopy, virtual chromo endoscopy in this score, which assesses the mucosal architecture and the vascular architecture. And this opened a gate for more sophisticated techniques like confocal laser endomicroscopy and endocystography. Both of them have widely gained an attention and accurately assess inflammatory activity and accurately predict clinical outcomes. But on the other side, interpretation of these scores is entirely subjective and depends on the expertise of the experience of the endoscopy. Returning back again to the subjectivity, and it requires high level of expertise and specialized equipments. And at last, again, artificial intelligence now could be a solution to overcome these challenges. Applying artificial intelligence for endoscopic scores reduces practice variability and improves endoscopy quality, and there are many systematic reviews and meta-analysis supporting using of artificial intelligence, but still we need more studies in order to recommend them routinely in clinical practice. In summary, endoscopic assessment of severity of inflammation with a scoring system provide objectivity, uniformity, standardization of reporting of mucosal appearance. Despite endoscopic scoring system limitations, as we said, like complexity, subjective interpretation features, lack of validation for some of these systems remain a valuable tool for augmenting clinical decision making and ultimately appropriate treatment targets and satisfactory patient outcome. Surveillance of adherence, dedicated training, and online tools can facilitate broader utilization by gastroenterologists and endoscopists. Using artificial intelligence system for endoscopic scoring may provide further improvement and standardization. And thank you for your attention.